Okay, so this is, well, I will show a case that we can discuss. This is a 36-year-old. He's a musician, no comorbidities. He plays in a gothic metal neo band. I don't know what that is, but he had a history of edema and redness 8 months prior consultation. He had some insurance issues. It took like 6 months to resolve, and his HbA1 was 12.6. So at the time, he got a lot of pictures, and he could like take a lot of photographs of his food during this phase that he was waiting for his insurance to get fixed. And this was the initial presentation. And this is how it looked. And after several months, he said the edema went away, as we all know, a couple of months, and this was the situation. So when I get to know him like 8, 10, 9 months afterwards, he was not using any regular shoes, he was using just Crocs. And this was the situation. Obviously, if we try to guess how the x-rays will look, we'll probably have this adduction. But we just discussed earlier that there are some crazy patterns out there, and not every case. I think that's why myself I like Charcot a lot, because not any case is similar to the last case, you know. And this is what I saw. And what do you guys think about this? It's a different kind of pattern that we all see in our regular basis. Ross, what do you see? What happened here?
I think the ligaments it's more of a ligamentous issue and a bony issue at that point. And I question whether or not we do actually need to be getting anatomical fixation, because what we're trying to achieve is a braceable foot that doesn't ulcerate and is stable. And so if you are, to get anatomical fixation with that is difficult, whether it's an open or a minimally invasive reduction. It's a big operation. And the bigger the operation you do, the more disruption you do to the soft tissues, the more risks I think you then get inherent. And so potentially your most minimal way of approaching it is to debride the medial cuneiform, which will decompress and narrow the foot width and take the pressure off where you've got your risk of ulceration. And if you need to put a couple of screws across the midfoot without doing anything else, you then make it not too stiff. And I think there is a real risk with more hardware that all we're doing is creating a stiffer and stiffer construct, which is actually not biomechanically what the bone and the ligaments really want to do. And so you then have the risk of progression of Charcot. So, as an orthopod treating an x-ray, the instinct is to put the bones back anatomically and hold them there with as much hardware as possible. But as a clinician treating a patient who's in front of you, that's got an ulcer, which is the thing that, if it gets infected, is the thing that's going to kill them in the longer term. If you can decompress that and do it as minimally as possible, it's got less trauma to them. And I think the nicer thing actually would be as if there was a way that we could predict, because you know that this foot, when it's hot and swollen, is going to drift. And the MRI tells you roughly where that's going to drift. I think the bigger question is whether or not we should be intervening at the early stage and putting some screws across at that point to prevent this from happening in the first place.
Yeah, well...
but all of that's controversial, so
yeah.
I'm sure everybody will shoot me down in full.
Would anyone think about glottal correction or external fixator at this point with this patient? What about our Italian friends? I will put this is the lateral, so it's like dorsally subluxated.
Yes, it's like a typical dislocation of Lisfranc joint. Yeah.
Yeah, it's like a pure Lisfranc, and it went like.
Which one?
One square laterally, you know, because.
Yeah, the dislocation, lateral dislocation at the level of the cuboid, first metatarsal, other metatarsal shifting laterally, all of them.
And this is acute stage, right?
No, this is, I was going to treat it acute, but he has some insurance problem and he disappeared for 8 months. So this is now, it's now in the second stage. It's not acute anymore. He didn't get it also because he decided not to use any more shoes.
1-2
He just
months.
used some Crocs when he was out of there, and he made like a little like a window in the Crocs so that this this navicular would not like how do you say it, like wrap I guess it.
But yes, you need to solve
And this is the oblique view.
Yeah.
So, well, one of the things that we would like to ask, how do we have to achieve correction? Like, I think Ross said that we do not need like anatomical correction, but we need alignment more than anatomical correction. I think that we have been learning through the years that probably what we need to get in these patients is the relationship between the hindfoot and the forefoot more than an anatomical correction. And I think that probably that's the best way to go. So what would you do in Italy with this patient?
In this case, I do external fixator, but in any case, here you need to do open surgery and to open I will do two approaches, lateral and medial, and reduce this dislocation. Maybe we don't need to do it perfect anatomical way, but it's much important to achieve stability. And I put the external fixator separated from calcaneus, stabilization of calcaneus and talus, and forefoot half ring only for metatarsal. Do you help me to reduce it acutely in the operation room, or maybe just a little bit correction progressively in the postoperative?
Vast experience in external fixator techniques. Are you able to distract it in case you want to get, retain the length of the side?
No. I think it's better to reduce it in operation room acutely, open way and reduce it.
I've seen.
No.
Yeah.
But what I may say about external fixator, because I see your cases and maybe other cases. Many people say the people don't support external fixation, but the problem is not supported this. The problem supported the surgeon. They do this surgery because if you put only 2 wires, transverse wise like you want, you put external fixator, only foot frame, 2 wires in the calcaneus, 2 wires forefoot, it will never function. The patient will have pain, will have problem, will have anything you want, and hate you and external fixator together. The problem that you should need to do a really stable external fixator. Minimum, like I said yesterday, but for Liz Frank, you may put minimum 3 wires metatarsal, 2 wires with half pin and calcaneus, stabilizing the talus. In this way, the patient will be more comfortable because the frame is stable. If you don't do it, better don't use external fixator because only became like a torture for the patient.
And if I can add something, the size of the foot plate matters. 180 millimeters foot plate is too big, and this will make the construct unstable. Even if you have more wires.
Open, reduce it, and then put it in, or?
No, I mean the size of your rings and of your foot plate makes a lot of importance in the stability of the frame, because you have more space between your skin and your wire. You don't need so much space, and this will bend the wires and will reduce the stability of the construct.
So, Bino, would you go minimally invasive on this?
Okay, so I had similar scenarios. In scenario wherein I can move easily, open up, and things that I've done open procedures, and I actually have a case exactly like this in my computer, but I don't know whether you have time to see this. And I was able to reduce it. And then put my rafting screws.
Acutely?
No, it was not. It wasn't acute, but it was not consolidated fully either.
Oh, okay.
So I'd made 2 incisions, one on the lateral, one on the medial, like I would do for a Liz Frank. But I put screw from the base of the second metatarsal into the cuneiform bone. That's my very strong construct I have, and that's number 1. And number 2, I put the other screws, and it worked out very well. Worked out in my hands. So I preserve the length, because sometimes, if you shorten 1 foot, then they complain, okay, I would have do 2 different pair of shoes. One side is smaller. And so you can preserve the length, and I understand what Dr. Miller was talking about, so you create more tension in the foot if you retain the length, but you lengthen the tendon. You lengthen the tendons and things like that. You can still maintain stuff. You have a comment, sir?
Yeah, I think that anyway, if you want to use some strategy or another one, the concept is we do with the Lizarov, so we do lateral medial approach, do through the Lisfranc. In this way, you can do at the same time reduction and fusion of Lisfranc. So you create correction and stability. So this is the concept that in another way, Dr. Rose Miller did the same, try to do, stabilize and create, some alignment or reduce. That's probably the principle of you did with the X-fix, with the rafting technique, but the principle is stabilize, this dislocation and reach the better alignment that you can, not anatomical.
So,
But
Will you throw away the uniform in the bed?
well, actually, I'm going to show you what we did so I can show another case. So this is what I thought. I thought, well, looks really well aligned, and maybe if we didn't, some of our patients that are plantigrade and they don't have ulceration risk, sometimes they have funny x-rays, but they go very well in a crowd boot so I thought, well, this is maybe this will go very well if I keep this. So in that way, I thought maybe I should take this out.
Yeah.
And Dr. Miller's approach made a lot of sense to me.
Open and remove that because I won't do that. I will probably do some MIS.
No,
You do that MIS.
no.
You lift. So you do it MIS. You peel it off, and you're doing your burr from inside out, and so you basically make that converts into a toothpaste that you extrude out through the MIS incision. You've not had to take off any of your tendons, and all
Yeah.
you've done is debulk it.
Well, one of our dogmas nowadays is no open surgery. Okay, so
you've
this is what we did.
So you
We took our bone burr and we do this is ostectomy of the cuneiform. We prepared it really well. We prepared the first TMT, and afterwards we start preparing. Well, this is our dogmas. We prepare the other joints, and we reduce the deformity. We took some ostectomy also from plantar, and we correct the equinus deformity. There's the TTC wires over there, and we do some beaming. We are now doing our lateral column beamings from the calcaneus to the 4/5,
Yeah.
I don't know if there's a base, but over there, and this is the approaches.
So again, the second, the second method, still missing the head of the tail.
Yeah, it's kind of rafting. It's a rafting technique with the beam. With the beam, we are rafting with the beams. Yeah, sorry. Here you can see in the yeah, it's okay, but people with beams still can be happy. Well, this is yeah, but maybe this is what it needs. This is the 2-year follow-up. And this is over there. Yeah, actually, this is the X-ray. It doesn't look very well. We have some fusions, but not fused at all. Some like 60% of the joints. And this is the patient walking. 2 years afterwards, he explained to me about the metal gothic musician scene, and he's now hearing his second album. Okay.
Guys, go back one place. So you see here, they might still get some ulcer under the cuboid. They might, but if you look at the tail of that first metatarsus beam, right, there is some radiolucency. So now my question here is: do you proactively go ahead and remove the screw, or wait
No.
5 years? Why not?
No, it's not necessary because the patient is we obtain the objectives. The patient is asymptomatic, It's working non-ulcerated.
These kind of scenarios are seen that it's getting destructive.
Yeah, but we don't see it. His pattern is so. Yeah, I think it's probably what happens is that there's some osteolysis and they had like a micro movement that it's what it needs afterwards.
It was a stable fibrous unit.
Yeah, and that's what it is. So just want to show you this. Just want to show you this last case.
Can I ask you why you fused the subtalar joint?
So there's some evidence that that's a point of failure. Dr. Vukic has done a lot of evidence in that. In our initial experience with the beaming, there was some mechanical failure, and all of them like slide out of it. So we're just doing it, and also it allows us for our tripod to be more stable. So we just surrender ourselves to make this tripod and the bone block. And I think it's a very important part of that. There's a lot of mechanical and clinical studies supporting it. So we just, like 4 or 5 years ago, all of our beamings are starting with the subtalar joint also.
For that,
No.
but it's a debate whether you need to add a subtalar screw. But it's a form of A-frame, so my opinion, mechanically, it's very strong.
Okay.
Yeah. So,
Triangular.
And
so I have a few minutes left. So I want to show you how we.
Let's keep moving on.
Yeah. So
This we have Dr. Watts.
yeah. So this is
Enjoy here.
yeah. This is how we're doing our. This is how we're doing our reconstruction cases with gradual correction. This is a 62-year-old overweight patient that he's a smoker. He thought he had already beat diabetes. He had a minor ankle inversion like 8 months before consultation while playing with his grandchild. He had an ulceration like 4 months ago. And the motive of consultation is especially because his wife is worried about the non-healing wound in his foot. This is the HbA1c1 level. This is the patient. Has this abduction chronic deformity. This is the wound. He had this like for 4 months. It hasn't healed. These are the X-rays. You see a total collapse at the mid-tarsal joints with a very, very confined equinus. So in these cases, what we are doing is that we are, in our concept, when we have severe deformity, we just don't do it with MIS because we think acute correction can be very dangerous in these cases. We have like vasospasm and also complications about doing like this very, very great corrections in an acute way. So what we are doing is like doing a two-step approach, because for us with that ulcer everything is contaminated over there, so we have to do it in a two-step approach. In an algorithm, this will be the way to go. So what we did is a triple tenotomy of the Achilles, equinus correction with K-wire fixation, IND from the plantar ulcer, ostectomy, and get rid of all this bone, and a bad frame hexapod. So this is where we are with the MISBOR. We're doing the midfoot osteotomies, just a straight line osteotomy. We try to avoid any articular joints. We try to go only in bone. We're not looking for a regenerate in this case. We just want to go and correct this and align it. Like I told you, I think that the key to this is more than anatomically reduction. It's the alignment. This is the configuration we are using. As you see, this has only small perforations, no big approaches, no approaches at all. This is when we started our distraction phase. This is the deformity, how we mapped it. Okay, this is very important for us. We do everything accordingly. This is the program. We map the deformity, the correction, and this is how it looked clinically. And from the AP point of view, then our second stage that we do in all of our cases, we prepare all the joints. And there's our beaming. And this is how it look afterwards. Only small poke holes. This is 3 weeks afterwards, a month afterwards, and this is what it looks like. We have like a very solid fusion of the meat food. Talonavicular not so much, but yeah, we are trying not to open these guys up, and this is the result. Sorry. So we can go from that to that. Also, not anatomical correction, just the alignment of the Mary's angle and in both projections. We can. I think the message for us is that we should avoid open approaches at all costs. I think that's the key for patients that succeed and not succeed, especially in this patient that was a heavy smoker. I think it's very, very important. So yeah, that's it. A smoker as well, yeah. Thank you.
So we're gonna
Work, guys.
great presentations.